I would ask you to do on a test is I'll ask you which classification or what kind of criteria do you use in pancreatic disease, which one you use for liver disease. Okay, in liver disease, it would be Child's classification. Pancreatic disease, it would be Ransom's criteria for pancreatitis. So that's the kind of stuff you sort of need to know. I don't need you to memorize all these specifics. It's a waste of time because you won't remember it in a week. So I'm not a believer in that. Okay, I just want to get you to have the concepts in your mind. How do I deal with this when I take care of somebody? If I hear achalasia, what do I have to think immediately? I got to intubate this individual. I have a foreign body inside the esophagus. What do I need to do? Intubate this individual. Apply it to what we do. Okay, I'm not going to ask you minutia. It's not my job to do that. Okay, and you're not going to learn that, and at least not for long. Okay, so again, Child's classification. You can sit here all day and memorize it as part of bilirubin, albumin. Yes, prothrombin time. Instead, what you need to think of is what is the liver process. Liver process is proteins. Okay, which the most important ones are clotting cascade proteins. So it's going to affect your clotting. Okay, it's also gets rid of bilirubin. Okay, so if you have diseases that affect the liver, where you start getting bilirubin cannot be broken down, you get an increase in it. And then you got to know the difference between conjugated versus unconjugated. I think that's important for you to know. Because then it differentiates between being intra or prehepatic or post-hepatic as an obstructive disease process. So those are the kind of things I expect you to know for this. Intraoperative management of patients with ascites is that you have, what you're trying to do is you want to decrease your portal blood flow. Things that are like muscle relaxants can decrease, can make the abdominal wall weaker and basically help you. You have decreased production of pseudocholinesterases by the liver, so one of the things that you may have is you can have increased duration of action from drugs like succinylcholine and mivacurium. So you all have to have that in the back of your mind in consideration. If you're going to give these agents, is it appropriate? Yes, but it's going to be maybe prolonged and may actually act like somebody who has pseudocholinesterase deficiency. There's also a significant increase in the actual volume distribution in these individuals from the ascites. So the actual, for non-depolarizing muscle relaxants, your volume of distribution is going to become an issue, and you're going to have to give more of it. I can give you a hint, though. What may actually help you not have to give a higher dose. And as you start your induction, you hit them with 10 of ephedrine or 5 of ephedrine. What that does is it vasoconstricts the blood flow to the GI tract system, and it forces blood flow to the skeletal muscles. Okay? So the actual dosing is, instead of looking at the large volume of distribution, now sees a smaller volume distribution, which is now going to go to the skeletal muscle. So that's a clinical thing that sometimes we consider doing to try to help us not have to give high doses of non-depolarizing agents in this kind of disease process. Okay? The other thing you got to be also worried about is that any drug that you give these individuals is going to be one additional drug that the liver has to get rid of. And if you give too many drugs to these individuals, you can get hepatic failure. Okay? Or medication just doesn't get broken down. So clearance becomes an issue in these individuals. Hoffman degradation is basically not affected by liver dysfunction, so it doesn't care. So things like atracurium is perfectly good to use in somebody who's got liver failure. Okay? And cisatracurium is the same way. So Hoffman degradation is a good thing. Fluid management, you have decrease in sodium clearance, and you have slow citrate metabolism. So when you're giving blood products to these individuals, sometimes citrate stays around forever and produces a very significant hypocalcemia in these individuals. Okay? Much more so than normal. So instead of having to just wait for 4 units of blood before you have to worry about hypocalcemia, you may have to worry about hypocalcemia on the 2nd unit of blood. Okay? The other thing you want to watch for is glucose monitoring. Glycogen is a very important byproduct of the liver metabolism to maintain sugar levels constant. So these people can become very brittle and develop significant hypoglycemia, which you're not going to be able to see under general anesthesia. So you've got to monitor for that. And you really have to consider invasive hemodynamic monitoring. The problem with that is that, of course, these people have a much higher risk of bleeding, okay, especially if you're putting central lines So, you know, if you hit something and it starts hemorrhaging up in the neck, you're going to have a problem. So just please be careful. Liver failure can be caused by many things. The most common that we see, not in the operating room, but in the ICU, would be viral hepatitis. The other things you got to think of course, is drugs. Things like acetaminophen, which a lot of people don't think of as benign. It's not a benign drug at all. It can cause liver failure. There's, of course, volatile anesthetics such as halothane that can cause it. Goodness for you guys is you don't see about halothane anymore pretty much. Things like the TB drugs, like isoniazid, things like phenytoin, sulfonamides, and amiodarone also can cause problems with liver failure. Toxins like carbon tetrachloride. Where is carbon tetrachloride found? If you were in my generation or a little bit older, we would take our clothes to dry cleaners. Okay? Carbon tetrachloride is part of the dry cleaning business. So you'll see people come in that work in the dry cleaning business. They're opening up the cleaning bin in the middle of process, and they'll be inhaling carbon tetrachloride. That's what they use as a chemical to clean the clothes. The problem with that is you inhale it, it can cause liver failure. Also some forms of mushrooms, which I've seen that happen before here. There's kind of a diverse culture here in Florida, especially it seems like in Everglades City. People seem to do mushrooms much more than I've ever seen, and our children are doing that as well. They'll do mushroom tea, and it can have some very devastating complications if they pick the wrong mushroom. And most people that are doing mushrooms, they either have a really good knowledge or they're just sort of playing with stuff, and they don't realize how dangerous mushrooms can become. And it can cause significant liver failure in these individuals. And that seems like 3 kids died from mushrooms when I was in ICU here some years ago. Vascular events, ischemia, as well as blood carrier syndromes can occur, and fatty liver, pregnancy, Wilson's disease, and Ray's syndrome. Ray's syndrome can also cause liver failure as well. Eventually, if you have liver failure, the only thing you've got left at that point is liver transplantation. And one of the things that I want you to be aware of is if we don't do liver transplants here, but if you do end up doing liver transplants, make sure you protect yourself. Okay? These people have a very high incidence of having hepatitis C, having some other kinds of viral contaminants that can really kill you. The other thing is that these people are going to bleed like crazy, like you can't imagine. Okay? It's the first time I've ever given somebody 80 units of packed RBCs and over 140 units of FFP. That's a lot of blood. Okay? When I was actually working in the room, we had 4 people trying to keep this person resuscitated. My attending got so desperate trying to get the person to resuscitate that we actually broke the top off of the resuscitation device, which looks like a washing machine, because we couldn't pump the blood in fast enough, and we started cutting the bags. That's bad. Okay? When you're cutting the blood bags with trauma scissors, just to spill it into the container, just give it to the patient at 6 liters per minute. Sorry, 6 liters, per minute. That's how fast we were infusing it, and we were barely keeping up. When we actually finished the operating room, it was like a giant pool of blood. As you can imagine, that's not really healthy for you. Okay, so that's why I'm not a big liver transplant fan. I've been in 2 of those like that, and I've done like 6 of them in my life. I don't ever want to do another one. You do have to put arterial lines in these individuals. Usually you put in 2, believe it or not. Okay, you put 1 in each extremity. Sometimes we'll even put in the femoral one as well to add to more information. PA catheters are almost always required because there's so much fluid shifting taking place. You have to have 2 level 1 transfusers at the minimum. Okay, in our center, we wouldn't even consider a level 1. It wasn't enough. We would actually do the big devices. Well, I can't remember the name of it right now, but it's basically a device that has a roller pump in it that you can pump blood in at very high speeds. The problem with that kind of thing is it can push it in so fast that you can overwhelm and could produce congestive heart failure. Basically, you avoid nitrous oxide in these cases because you cannot have any kind of gastric distension in these individuals when they're doing the liver transplant. You're going to be doing lots of frequent labs, including TEGs. Well, you know, how many people know what a TEG is? Transelastogram. Okay, it's basically you take the blood and you put it inside of a powder. Okay, and then it's got a wire that goes into the powder and the blood, and basically it's a strain gauge to tell you the degree of how clotting is taking place. It'll tell you if you have plate dysfunction, if you have problems with, if you're having lack of fibrinogen, if you have a lack of PT, PTT. It doesn't give you numbers, but actually gives you a graphical representation, which then you have to interpret and figure out exactly what's going on. So if you are going to go and doing liver transplant, that's really something that really interests you, then I would recommend you read about TEGs, because that's something you are going to encounter. This will be a very useful tool. You also have forced air warmers, and make sure that you follow the immunosuppressive protocol. The induction for all these liver transplants is they're all high risk for aspiration, so you have to do rapid sequences. Succinylcholine is still considered safe, even though it has a prolonged effect. Who cares? The operation is going to be 6 to 18 hours, so you got plenty of time for the succinylcholine to wear off at that point. Okay. What we use is we use the Hoffman degradation products, which is we use atracurium and cisatracurium commonly in these individuals. The downside to this, of course, is it causes histamine release, but you have to muscle relax these people intensely. So most of the time we use cisatracurium at high doses because it tends to have less histamine release than atracurium. You basically have to be at 0 twitches when you're doing a liver transplant. Okay? You want to have no motion in the muscle. The surgeon's having a hard enough time working in a fairly tight spot, and it's a big operation. Okay, now you have to understand that when you do a liver transplant, you're going through different stages. Okay, and this I think is important. That's why I put it in here for you. Okay, there's what's called the pre and hepatic phase. Okay, this is before the liver is removed. Okay, it's basically at that point they're removing the native liver. Okay, so you want to keep up with your blood products at that point. A lot of times consider giving these people cryo, FFP, and platelets. Usually the TAG will actually be very helpful in telling you what's going on. If you have hemodynamic instabilities due to cardiomyopathies, the liver is actually removing a lot of toxins. In this case, it can't. So these people develop cardiomyopathies due to toxins in their bloodstream. They usually have very significant forms of acidosis, which you have to correct. And hypocalcemia can become a big issue, especially as you're giving blood products. They can get citrate toxicity where they develop very significant hypocalcemias, and then the bleeding just doesn't stop. So that's another thing you've got to consider in the back of your mind is hypocalcemia. A lot of times you have oliguria, which is lack of urine output, and Lasix and mannitol may be indicated. And if the person has increased intracranial pressure, that person has really a poor prognosis and may not do very well. May never wake up from the actual surgical procedure if you're not careful. Then you go into the next step where they actually remove the liver, and there's no liver now. That's a weird stage for your body. That's called the anhepatic stage. Okay, that means without liver. Okay? Now your body is sort of sitting there going like, where is my protein factor? Where's my glycogen factory? So my sugar levels begin to drop precipitously in this individual. So you got to really keep an eye on your sugar levels at that point. The other thing that the liver does is it basically helps break down acidosis, and now like the kidney does. So you have lost that, so you may actually go into very severe forms of metabolic acidosis. The question is, how do you treat this? Because these people are also hypernatremic. Can you get bicarb? What's bicarb got in it? Sodium bicarb. So then you got a bigger problem. You're continuing giving sodium bicarb to try to reverse the acidosis, but you can't, and then you're causing the sodium levels to get so high that the brain becomes, denatured. Basically, it squeezes itself. It loses all its water content, so it kills the brain. So you got to be very careful in that respect. What you do is there's different forms of treatments for acidosis that you will see in no other therapies. And I think it's out of the scope of the discussion right now. But just know that there's other compounds that we use that treats metabolic acidosis without bicarb. Okay? And when you get into that, you can actually talk to them guys about that. You also see decreased drug metabolism, of course. Citrate intoxication is very common at that point. So calcium infusions usually are started at that point. Okay? Then you get the new liver, and it's amazing when the new liver goes in. The body literally changes color. Okay? When you look at somebody who has no liver or a very diseased liver, they have this kind of yellowish tinge to them. They look really sick. And within 15 minutes of the new liver, the color starts getting normal. It's really amazing. When you take them out of the ICU, into the ICU, it's like a completely different person that fast. So the biggest problem at that point is that your anastomosis can break down. Okay? So that's when you get into major problems. You'll see that if a surgeon loses control of one of these major blood vessels, it can become a nightmare. That's when I was telling you about where you had 80 units of blood in a room. They lost actually control of the inferior vena cava, and it went up into the chest. Oops. Okay? Going after that sucker is pretty difficult. Okay? So, you know, when you get in trouble like that, it's not good. What you're looking at is you see a significant amount of hemodynamic and hyperdynamic instability. You get a lot of dysrhythmias, severe bradycardias. The dysrhythmias are commonly seen when the liver is reperfused because they use a high potassium solution. So if they didn't properly clean it, you can get hyperkalemic cardiac arrest on your hands. So then you're working to try to reverse the hyperkalemia. What's the treatment of hyperkalemia? Hyperventilation, calcium, sodium bicarb, okay, glucose and insulin, and all those things. So the hyperkalemic arrest is also a problem. Fluid overload becomes an issue. Body temperature sometimes can precipitously drop at this point because the liver that was just put in is also cold. And you get massive potassium acidosis, I just talked about. You can get also a hyperacute reaction. If that's the case, the case is over, essentially. It's done. If you get a hyperacute reaction, the liver will be dead right in front of you, and that guy is going to die. Okay? Thank goodness it doesn't happen very frequently, but you'll see that if everything's done properly, you get a nice return of functioning liver. Now, I know some guys that are very, very good at doing liver transplants. The guy in Miami is excellent. He can usually do it in about 6 hours, which is pretty impressive. And the patients do very well there. Where we were doing it, it was a new guy. It was a disaster. They eventually took away the liver transplant service from us, which was a good thing. I was happy because they were doing people in all the time. So now they're doing it better. They got a new surgeon out there now who's doing a better job. So they reopened it, and I think it's working out better for them. But just know that these are not joke cases, and you've got to be in your top of your game when you're doing this. The post-transplant patients are immunosuppressed. A lot of them have already underlying renal insufficiency, and a lot of them already have VQ abnormalities from AV shunts that also be considered about. Up in Chicago, I also worked in the liver transplant unit, and I was one of the ICU guys that received these patients. And they could be very daunting in some of their hemodynamics, and they don't act like they normally do. You sometimes have to give them drugs that you would not normally expect to work, and it actually works because the liver is not working properly. It's processing stuff, and some of the breakdown products of other catecholamines are actually deleterious and are not properly doing their job. The next one is biliary tract disease. You have cholelithiasis, which is basically stone in the duct. This may actually be silent, and it actually occurs in about 10% of all adults over the age of 40. Females have a higher incidence than males, and obesity is a very strong association with cholelithiasis. Eventually, you get intermittent obstruction of the cystic duct by the stone, which develops into biliary colic. And if you get obstruction of the cystic duct, which is the duct that leaves the actual gallbladder to the common bile duct, that's the cystic duct. If you get obstructed that, you can get what's called acute cholecystitis. And the gallbladder becomes acutely inflamed and very mad, and it becomes very uncomfortable for that individual. The way we treat that is we do an urgent cholecystectomy in that individual. We do a lot of gallbladders. I mean, a lot. It's unbelievable how many. I think it's done more so than we do appendectomies. And so there's a lot of disease because of the bad diet that people have. Okay? It's infrequent to see it in somebody who's thin. The reason you're seeing it if the person is thin is that they're on certain kinds of diet plans. They lost a lot of weight, okay? Or they're on some kind of freaky diet where they're taking all these kinds of drugs that are causing their liver to produce all this extra junk. So most of these people, though, have high fatty diets and as a consequence develop biliary tract disease. This is what you see. Here's a gallbladder, and it becomes a duct stone in here, the cystic duct, and it becomes obstructed. Okay? This is what it looks like. This is a black and white picture. I wish I had a color one, but this is actually all stones. Look how many stones this person has inside the gallbladder. So it takes time. It doesn't happen overnight. Okay? Biliary tract stones, eventually the acute cholecystitis. will cause cystic duct obstruction. They'll get paid nausea, fever. Urgent cholecystectomy usually is indicated at that point. If it's chronic, it gets intermittent obstruction. Choledocholithiasis means there's a stone in the common bile duct, which is much more serious in that sense. You've got to clear that stone. Otherwise, the person's liver will fail. Okay, so usually we'll do what's called intraoperative cholangiogram, which will actually put a catheter inside the common bile duct and then shoot dye into it to see that there's no stone in it. If there's no stone in it, then we're done. If there's stone in it, the surgeon can try to extract it. If they can't extract it, then the person goes for ERCP. The problem with doing an ERCP after a gallbladder is that you have a suture line, and you're putting pressure from below. So you can perforate the actual attachment from the cystic duct that was there before with the common bile duct. So that's an issue as well. If the stone goes all the way down to the sphincter of Oddi and it obstructs the pancreatic duct, you can get gallstone pancreatitis, which we just talked about in the last lecture. Again, anatomy, you have to understand how the cystic duct attaches to the common bile duct, which then attaches to the pancreatic duct. Does it always attach to it? No. There's a variant. Here's a variant. The variant is that you have separate, you have two holes. One's the pancreatic duct hole, and the other one is the common bile duct hole. Okay? It doesn't happen maybe less than 5% of the population. Most of the time you'll see it's a common duct that's a connection between the cystic duct and the pancreatic duct. Ultrasonography is the treatment, is the diagnostic treatment of choice. CT scan follows very closely. ERCP is this device where we do an endoscopy and we look. And the interesting part about this is you got to remember is that when you do an endoscopy like this, is that the port that's watching is side port. So the actual endoscopist cannot really see directly in front of him. He's actually seeing on the side. Okay? The other thing that's important I think for us is as you pull back, as they're holding this in place, the way they're seeing is they're insufflating air. Okay? So all the air is going down to the small bowel, and it's also backing up in the stomach. So the stomach is usually very large by the time they're done with the ERCP. If you have a good endoscopist, which is most of our guys, as they come back, you'll see them stop in the stomach, and you need to watch this. Okay? You need to watch as they deflate the stomach. If the guy is in a hurry or just forgets, he'll pull the scope all the way out on you, and it will not the air out the stomach. And as soon as you pull the endotracheal tube out, the person will vomit. And that can aspirate on you. So if you have somebody that's not clearing the stomach for you, you can complain, which I do, okay, and say, hey, did you empty the stomach? And they go, oh, I'm sorry, but they'll remember next time. Okay, you have to be kind about it, but just don't be a jerk. But just you guys sort of remind them, hey, come on. And then you put an gastric tube real quick, empty out the stomach before you extubate the individual, and then you're safe. Okay? In the old days, medicine was very strange. People used to do very odd stuff. They would actually think it was funny that you would be vomited all over, or somebody would defecate all over you, or something like that. It was just kind of a very childish thing that I never understood as part of my training. And things people would leave the stomachs full like that just to get you to have to clear it. And then putting that patient at risk in the process. So to me, it was very childish. But things that you may see somebody older doing stupid stuff like that because they think it's still funny. Okay? It's not appropriate. But I'm just sort of warning you ahead of time because you may encounter idiots like that. Cholecystectomies is a very common procedure that we end up doing. It's done laparoscopically. It causes high intra-abdominal pressures from the actual CO2 that we use. You can still use nitrous oxide. There's no contraindicating to using nitrous oxide in gallbladder procedures. Some people tell you that it distends the GI tract. It's a bunch of BS. It doesn't unless you have an obstruction in taking place. So nitrous oxide is only contraindicated in GI surgeries if you have any kind of obstruction, okay? Or you have, peristalsis problems, maybe also a consideration. But in normal circumstances, most people with gallbladder disease have no contraindication using nitrous oxide. If you have gastric distension, then you consider RSI, rapid sequence induction, and put an oral gastric tube after induction every time. The reason you're doing that is you want to empty out the stomach so the surgeon can work more efficiently during the gallbladder procedure. So everybody that has a gallbladder procedure should have an oral gastric tube put in them. Do not put an NG tube because that tube's going to be pulled out at the end of the case. And if you put an NG tube and it causes nasal bleeding, nobody's going to be happy. Okay, so don't do that. There's a lot of times vaguely mediated bradycardia from peritoneal stretching, and that insufflation pressures lead to a decrease in venous return. Increased SVR is due to CO2 absorption, which is the only reason why you don't get hypotensive during cholecystectomies. What they'll do in the operating room is they'll tell you, please put the patient in gallbladder position. And you'll be going like, oh, I'm a new student here. I don't know what I'm doing. Okay. And it's not your fault. You've never been told what the hell the gallbladder position is, so I'm going to tell you what it is now. Okay. Patient is usually flat at that point, supine. Okay. What they want you to do is they want to be able to visualize the right upper quadrant. And they want the actual intestinal tract away from the gallbladder. So they'll put the patient in reverse Trendelenburg, so head up, rotate towards the surgeon, which is always he's always to the left. So it's a reverse Trendelenburg with a left lateral tilt. Okay, so you got that patient in that individual. Now, if that person was basically sitting there, okay, and under anesthesia, and was not insufflating CO2, okay, you would get severe hypotension. Severe. Okay, all the preload would go away to the legs, and you'd have no blood pressure. Okay? That's why you're never asked to do this procedure until after they enter the abdomen and insufflate with CO2. So they're not going to ask you to do this when they're prepping. They're going to ask you when the surgeon's already starting. So you got to be ready. Okay? The reason that you're able to support the blood pressure, though, in this weird position, is because they're insufflating CO2. That CO2 acts like a neosynephrine drip. It's a very much a alpha vasoconstrictor. So the SVR is maintained in this situation. Okay, some people will actually get fooled into running after the hypertension that you get. They'll keep cranking the gas. Okay? Just what I want you to do at that point is watch the CO2. If the CO2 is rising rapidly on you, the reason it is the actual the trocar that's in the patient is not in the right place. The trocar is actually in the subcutaneous fat layer. The surgeon may still get some air of some CO2 still going into the peritoneum and insufflating it, but the actual fat is now absorbing all this CO2 because it got the trocar partially out. The surgeon will yell at you and say, no, no, it's not me, it's not me. Okay? All you got to do is put your hand down the person's chest. Don't get into the surgical field. Nothing funny about having your hand come out to the surgical field and say, hi, I'm here. Okay? That's not good, okay? Okay? So as you put your hand down on the person's chest, you will feel crepitation. So you'll feel air bubbles underneath the skin. If that's the case, the surgeon needs to address it. And you guys say, look, I got crepitus. And then he'll address it. At that point, he can't argue with you. Okay? And usually they'll adjust it, and all of a sudden the CO2 values will fall, and then the blood pressure will fall. So don't chase the blood pressure by increasing your volatile anesthetics, because it's a surgical problem, not what we're doing. Okay? Sometimes it's inadequate ventilation can also be a problem, especially somebody who's morbidly obese. The good thing is in putting somebody in reverse Trendelenburg, usually the FRC improves significantly, but it's usually not a problem for us in that situation. It's on the reverse side when you're doing like an appendectomy and somebody who's morbidly obese, and they got them pretty much with their feet up in the air and their head all the way down. That's really difficult to ventilate. The other thing that you got to be careful with is I'm not going to pre-treat these people with opiates, okay, because opiates can cause biliary spasms. So I try to avoid the opiates until the surgeon's done. Okay, it can also mimic a bowel obstruction. So I tell you be careful. Okay, is it likely? It's a theoretical concern, and that's why I don't give narcotics until the surgeon's finished. At least when he's finished with the actual injection of the actual common bile duct. Make sure that everything's okay. If you did make that mistake, then you need to consider giving glucagon or Narcan, which I'm really not a fan of. Okay, because now then you have no way of giving this person pain control afterwards. Okay, nitroglycerin will also reverse the effects. Okay, so that's it on this section, and we'll give you guys a 5-minute break, and we'll start with the next one.